Well, we're having lots of hellos on the chat. So hello, everyone, and thank you very much for joining. Let's kick off. Welcome to our first online Alport workshop, the question and answer series. Thank you very much for joining us this afternoon. My name is Rebecca, and I'm a volunteer with Alport UK. Before we introduce our panel, who you see before you, I know a lot of us are new to Zoom. So we'll guide you through some of the basics before handing over to our panelists. The faces you can see here are our panel today, our kidney and genetic experts. But because so many of you have been able to join, we won't be able to see or hear you, but we're looking forward to communicating and typing with you. Another volunteer, Dan Long, who you can see at the bottom there, is controlling the microphones to make sure that over the next 2 hours, everyone is kept muted, other than those presenting. But today it's all about questions and answers, and we are therefore keen for you to be able to submit questions to the panel. I am now sharing my screen. And this is just to confirm how some of that functionality works. So moving your mouse to the bottom of the screen, you'll be able to see these icons at the base: Q&A, raise hand, and chat. To ask a question to any of our speakers, just press Q&A. Write your question and click send. Or if you'd prefer not to have your name associated with the question, please click send anonymously. Please ask as many questions as you like and whenever you like. Another member of our volunteer team, Patrick Walker, who you can see there, will collate these questions throughout the workshop. Today, we've got 4 presentations based on the most commonly asked questions from our Alport warriors. After each presentation, Patrick will pose a selection of your questions to the presenter. After all 4 of our presenters finish, there's time for more questions at the end. We'll ask our experts to respond to any unanswered questions and share them on Facebook later this week. So let's all try it now. Please click Q&A and write in the box one question that you would like answered today. That's one question that you would like answered today. If you're having any difficulties with Zoom, you can press that raised hand icon in the center, and Dan will get in touch with you and try and help out. Good to see you've got a few questions coming in. As you do those, you'll see there's a chat icon on the left. This is used to share your thoughts and your feedback. Please click it to open it if you haven't already, and you can see people's communication there on the right-hand side as they've said hello. So to recap, the Q&A icon is best for asking the speakers questions. The chat icon is for your thoughts and feedback. And if you're still confused, hit raise hand in the center. This technology is new to us all, so do bear with us as we trial these online workshops. For those unable to attend or finding it tricky, this is recorded, and we'll be sharing the recording of our panelists on Facebook tomorrow, so you can play the video if you miss anything. over the next month, we've got plans to use this format a lot more to share the latest research on Alport, and we'll be getting your input into that. So Patrick, over to you.
Okay, brilliant. Thank you very much, Becky. I want to say before we start, we're going to be asking for your feedback. So if you have any thoughts on how this went today, just keep those words in your mind, and we'll feedback later. Before we start, I want to fully introduce our panelists to you. Firstly, Professor Neil Turner. Professor Neil Turner is the Professor of Nephrology at the University of Edinburgh. He'll be taking us through COVID concerns for renal adult patients. Our second speaker tonight is Professor Rachel Lennon. She's a paediatric nephrologist at the University of Manchester. She'll be taking us through COVID concerns around young adults and children, as well as a little bit about Alport and its research. Thirdly, Professor Francis Flinter, the Emeritus Professor of Clinical Genetics at Guy's and St Thomas's, will be talking about the genetics of Alport syndrome and why it affects different parts of the body. And we will cap the whole thing off with Elizabeth Watson. She is the Principal Clinical Scientist at Bristol Genetics Laboratory, and she'll be taking us through the genetic testing process. I know that's a lot. We're going to start with Neil. Neil, would you mind sharing your screen now?
How's that working? All good. Thank you very much. I think I promised that I would say a little bit to Susan. I would say a little bit about what I do. So I'm an adult nephrologist here in Edinburgh, though I've worked quite widely across the UK before. And I've been interested in Alports originally as a scientist, trying to study bits of the basement membrane, but as the years have gone by, increasingly as a clinical problem. And about 20 years ago, I started working with the children who move up into the adult sector. So inherit quite a lot of patients with a number of genetic diseases, but particularly Alports. Now, today, a lot of the questions that were asked were around COVID. And so most of what I say is going to center on how COVID is affecting things, but it's useful to have that background about me because it means I can hopefully answer some other questions too. And the first thing I was going to talk about was there's been quite a bit in the press and in the news about both aspects of COVID in the kidney. So first of all, the complication that a lot of patients with COVID, serious COVID infection get when it affects their kidneys as well. But secondly, the question which is really important to the audience here is what if you have kidney disease and COVID infection gets to you? And of course, that's a question that lots of our patients are asking at the moment. And indeed, it's been dominating our working lives in the last few weeks as well. So to start first with acute kidney injury, so kidney failure that occurs during a severe illness, previously called acute renal failure. And the first thing to say is that it's actually not rare for a patient with severe pneumonia who needs to be put on a ventilator to need temporary dialysis. If those patients survive that very serious intensive care illness, and the majority do in those circumstances, usually their kidneys recover. Although the older you are and the sicker you are before this happens, the less likely you are to have complete recovery, and some people suffer significant lasting kidney damage as a consequence. Now this applies to people with no previous history of kidney disease too. Now, we were led to believe from the early news from China that acute kidney injury in COVID was very rare, and therefore we weren't quite as prepared as we were for scaling up the number of ventilators as we discovered we needed to be for acute kidney injury. And you'll have heard a little bit about that on the news. If we were to look at this map on the right of the picture here a month ago, it would have been really much brighter pink across the whole thing, and that would show how many patients in the UK had symptoms of COVID infection at the time. It's now down to round about 250,000, which doesn't sound a tiny number. But it doesn't mean that the epidemic is dying down. And in particular, kidney units are now breathing a sigh of relief and being able to think a little bit about where do we go from here, just like we are with the restrictions for everything else. But the reason it was such a big burden is that I think everyone is aware of the huge pressure on intensive care units, the sudden rush of patients as the curve rose and the number of infections rose. And it turns out that about 22% of patients who went onto an intensive care unit with COVID infection in their lungs developed kidney failure that needed some form of dialysis support. And it's really absolutely nothing of a surprise that those who needed dialysis in intensive care did less well, because in all intensive care units, having acute kidney injury is a marker of more serious disease. Really, whatever the cause for going into intensive care is, the more seriously ill patients get kidney failure. And I think you'll already know that patients with COVID infection who need to go onto a ventilator have actually pretty shocking bad outcomes. So even for an intensive care unit, it's pretty sad. Not much more than half of patients who need ventilation, and remember this is a small minority of the people who get COVID infection, recover. And if you have kidney failure as well, a marker of more severe disease, it's even less good than that. So a very severe infection that suddenly produced enormous pressure on staff. And the challenge really was scale. So they found they didn't have enough machines. They quickly ran out of disposable equipment, the lines that join the artificial kidney to the patient, and of course the artificial kidneys themselves. You might think that we have a huge amount of haemodialysis going on just to keep people alive. So couldn't we just pull in some of those staff to do that? But remember that they had to carry on all of their normal things, and in the areas where this was really a bad epidemic, quite a lot of their staff were off with illness or being isolated because of illness. So there's a huge problem with depletion of staff happening at just the time that this crisis hit. On top of that, the extended intensive care units in many hospitals, which were multiplied to 4 and 5 and more times their usual size, meant they went into territories that weren't set up for this kind of treatment. So one of the solutions that was found to this was to introduce peritoneal dialysis, which is certainly used for end-stage renal failure. So many patients are kept alive by peritoneal dialysis, but which in the UK hasn't been used very much for acute kidney injury since probably the late 1980s. So it's a long time ago. And really, to everyone's surprise, this was amazingly successful. Patients with COVID seems to clot their blood very easily, and that made it really difficult to keep the machines going. It gets around that problem, it controls their high potassiums, and it keeps them good, and in many ways is less disruptive than standard hemodialysis or the equivalent continuous treatments. And the latest national guidance about providing dialysis for patients with severe COVID infection includes quite a large section on using peritoneal dialysis, tube in your tummy, and washing fluid in and out. But the people who've done these treatments have included anyone who knows a little bit about kidney medicine you can train, and it has included lots of consultants coming back, specialists from other areas. It's been absolutely fantastic to see how hospitals have responded to this enormous challenge, actually. So that's just a bit about acute kidney injury, and the severity of it has made people ask whether there's something special about COVID infection, and does COVID affect the kidney? Do patients with kidney disease need to be particularly afraid of it for that reason? There was a hint early on that some of the patients with COVID infection had a lot of protein in their urine, something which people at Alports will know about, in addition to the rate of kidney injury and failure. And there was this clotting issue where the blood clotted very easily, and people wondered whether the kidney arteries were clotting up. Well, we don't really have the full story on this yet, but the picture on the right here is from one of a number of patients studied in China who had acute kidney injury in association with COVID infection. And basically, the message is, please ignore the color differences between normal and the picture on the right. That's just to do with the staining technique. The issue here is that these cells here, and this is a glomerulus on the left, there's the filtering unit, which you'll have heard about, and Rachel will show us more detail on later, I think. But these bits here, these are the wiggly tubules. The kidney tubule leads from the glomerulus all the way down into the collecting system, in which the urine is processed and most of it reabsorbed back into the body. The cells in this area are very abnormal in this picture. They're quite damaged and injured, and this is the main story. There are one or two unusual features that have been picked up in patients with COVID infection, but none of them are really looking like providing a good story that the virus does anything very substantially different to the kidney in the majority of cases. Mostly it just looks like severe acute kidney injury of the kind that you get in serious illness. And that means that neither Alport patients nor other kidney disease patients need to have that element of concern that there's a particular issue that will interact with their underlying kidney disease. On the other hand, this is pretty much an insult to the kidney, and if you already have kidney damage before this starts, it may leave you with some lasting damage. The other question which came up a lot, very early on during this epidemic, there were some concerns that patients treated with ACE inhibitors and angiotensin receptor blockers, these are common drugs for lowering blood pressure and particularly used in patients with proteinuria and particularly valuable in Alport syndrome. There were concerns that patients on these medicines seemed to be doing worse than patients who weren't. Now, the difficulty is that we know that patients who get this disease badly are elderly, and they have many other diseases, including high blood pressure and heart disease, exactly the kind of diseases that you would think would get them put onto these medicines. And it turns out that not enough compensation was being made for those issues. Animal studies using these drugs gave both good and bad arguments for it. There were some suggestions that these medicines could actually protect you, but other suggestions that they might be bad for you. But actually further human studies, and there are a whole series published just last week, summarized in this reference at the bottom, further studies have been really very reassuring. When you do compensate properly for that background illnesses in the patients who get severe COVID, there's no suggestion that these are doing you any harm. One of the studies even suggested they might be doing you good, but I don't think we can assume that that's a real issue. The next question, therefore, becomes, clearly you should stay on your ACE inhibitors. The next question, therefore, becomes, what do we tell kidney patients about the risk, about their risk from kidney disease? Here, the government has set out one set of recommendations, and we're aware that patients have had a whole variety of different bits of advice that may have come from different locations, so it's quite tricky. The recommendation is generally that transplant patients initially were told to shield and dialysis patients didn't need to bother, and that there's a sort of gradation of severity of CKD from stage 5 right down to probably CKD 1 and 2, which applies to many patients with Alports actually, that they have pretty near normal risk unless they have nephrotic syndrome, so a very severe protein leak or other risk factors. We'll just mention in a minute what that means about how you should follow, but I want first of all to say something about the actual risks to transplant patients and hemodialysis patients. Talking to people working in kidney units, their feeling has been that transplant patients have not been a great problem. They haven't seen a lot of admissions of transplant patients, and the ones that they saw weren't doing too badly. But just this week, actually, a UK-wide study has suggested that there is significantly increased risk for transplant patients, just as we thought there probably would be because of their immunosuppression. Maybe the reason we weren't seeing so many infections is because they've been so good at looking after themselves and they haven't been catching the infections. And this rather complicated paper here gives you the risk factors for all sorts of things. And I just want to point out two things. First of all is that young people, and by which they mean less than 45, are at much lower risk than average for the general population. And old people are at much increased risk. Well, we already know that, but it's a very extreme range. So people over 80 are really at 10 times risk, and people under 45 are at quarter of the risk, and people less than 40 are at vanishingly low risk actually on these estimates. And you need to remember that if you're trying to work out what your risk of getting into trouble is. Here, people with an organ transplant, about 3/4 of whom will have kidney transplants, are about 4 times increased risk. Okay, so it's significant and we need to pay attention to it. The news for hemodialysis patients is quite complicated. In the intensive care series, it turns out that some of the patients who were given dialysis and so on were existing hemodialysis patients, and sadly their outcome was no better than those with acute kidney injury who had done quite badly on intensive care. And the other bad news is that patients who come into hospitals to get hemodialysis have had quite a high rate of catching the infection. So that if you look at England as a whole, about 9% of hemodialysis patients have tested positive in this first wave of infection. And that's quite scary. Their risk of doing badly with the infection is also significantly increased. So it's said that maybe as many as 1 in 5 of them get the infection so seriously that they die from it. Now you've got to remember, and Alport patients are not typical hemodialysis patients. Many hemodialysis patients are quite elderly and frail, and therefore these risks are trying to mash all of these things together. And if you're young and otherwise healthy and on hemodialysis, your risk is much less than that. And it's a really important question in general. If I get this infection, am I going to do terribly? Most of the patients we've seen with these infections have actually done very well. The great majority have recovered very well. And in particular, patients who don't have the other risk factors that we know make you do badly do mostly extremely well with the infection. So
I just wanted to jump in, Neil. We have about a minute left, just because people have a lot of questions.
Yeah, I'm really sorry. So I'm
go
through this. You'll know that we've changed services enormously to cope with this. We've had to split renal units into COVID positive and COVID negative teams. Because of this dialysis issue, we've had to isolate zones or whole units. We've had to try and fix safe transport. We've had to cancel anything non-urgent and transplantation, even though transplantation seems in many ways to prevent you from getting into serious trouble with this infection. And the things that we're doing to compensate for not bringing patients up are, at the moment, they're very time consuming. Now, I know that some of the questions are going to be, how do we cope with living in lockdown? And maybe this will come up a bit, but essentially, if this is going to go on for another year or more, we're going to have to, all of us, decide what compromises we can make, because not many people can maintain complete shielding for that duration of time without either going crazy or really leading a miserable life. And it'll affect all sorts of things like, when do I start dialysis? What type of dialysis do I choose? Maybe those treatments that keep me home are a better thing. And a reminder really that it remains as important as ever to keep healthy, exercise, do all the things which you know you would like to be doing if you had more time for it at home. There's a couple of links there for further information, but even more than that, there's some time now for questions. Thank you very much. Sorry, Patrick, that was a little bit over my time.
It's no problem. It's no problem, Neil. I think we all find it extremely useful. I think a lot of the questions that I've got here, by the way, if you have any questions having watched that talk, please do just keep asking them. I'm going to go through what I've got here. Unsurprisingly, I think a lot of the questions that I've got are revolving around what is the best practice under this pandemic. A particular question on what to do. I think a lot of people, even with stage 1 or stage 2 kidney disease, got very worrying messages from their clinic. Should we be acting in any way different to the general public advice?
You know, at stage 1 and 2 kidney disease, particularly if you're a young Alport patient, I think your risks are very similar to the background population. Mm-hmm. And again, if you're young, that is actually very low. It absolutely does not mean you can ignore all the precautions that the whole population ought to be taking, because nobody really wants to get this infection. There are a few patients with Alport syndrome who will have such a heavy protein leak that they're running low proteins levels in their blood. Now, they are at increased risk because we know that those individuals are more prone to infections anyway. Most other Alport patients with normal or very near normal kidney function don't need to be quite as obsessional as those patients with much more severe kidney impairment. If, on the other hand, your kidney disease is more advanced and you have stage 4 or stage 5 and getting down towards 20% kidney function or something like that, then probably the risk of getting infection is no higher. But I would think that the risk of you getting acute kidney injury on top of it, if you're unlucky enough to get the infection badly, would be enough to make me strongly recommend that people at that level of kidney function are really good about protecting themselves without being quite so extreme as shielding, maybe.
Do you think it would be responsible for people with perhaps the lighter stages of kidney disease then to do things like going places for well-being, going on walks in places that might have other people?
Yeah, I think if you're a youngish transplant patient who's otherwise well, and this is going to go on for a year, you're going to need to do that to stay sane and healthy. And clearly, you would need to be extremely careful about it. And there are going to be times over the next year when the infection increases in incidence again, and we should probably tell people to stay home, and when the infection is low, and the risks of going out there are not so high. And everyone's going to be influenced by who they live with and what their opportunities are and whether they have a garden and so on. But they're really things to discuss and think through carefully.
Sure. Another question I think we had on the practicalities of being a kidney patient during the pandemic is something that I've had to do over the last month, which is sort out blood tests.
Yeah.
Should we be trying to book our blood test and going into clinics and continuing normal practice of monitoring, bearing in mind that there is this pressure on the NHS and there's this desire to stay at home as well?
Absolutely. And the last thing people who are at high risk want to do if they can avoid it is go to a place where the patients with infection are taken.
Exactly.
So it's very understandable, and we're not keen on it too. And yet, on the other hand, we monitor lots of patients who have kidney transplants and who have advanced CKD who need blood tests. And actually, they need to be seen from time to time as well. So we need to work out, as kidney doctors, how we're going to do that safely. In Edinburgh, for instance, we've organised a van which drives around and parks in car parks around the city that people get appointments to go to rather than having to go to a healthcare facility. On the other hand, general practitioners are actually getting their act well together to continue to provide services. And for many people, that local option is going to be the best way. These things are going to vary locally and are something that I hope your unit will be in touch with you about.
I should say my hospital, the Churchill Hospital, has actually managed to stay COVID-free. So it might be worth, if patients are worried about getting blood tests, just checking out the specific instances of the ward. I completely agree. Have you seen anyone with Alport syndrome who has also ended up contracting COVID so far? What
Do you know,
What are the
in
circumstances
Edinburgh,
of
I'm
that?
not aware that any of the patients that I've been looking after locally have contracted it, which means they either haven't or they've had it so mildly they've not even been tested, because it's relatively recent that we would test anybody, but we would only test the people who were, coming up to the hospital because they needed to be seen in A&E or something. So it's highly likely that some have had it, but none have had it seriously enough for me to have to look at them in hospital.
Well, that's great news. Steve Fry asking a really good question as usual. He was thinking about donors and the issue of having one kidney. Normally, I think we would consider donors to be completely fine under a COVID pandemic. What what's the circumstances that donors now find themselves in terms of their need to shield and self-isolate?
So the huge majority of donors are going to be absolutely fine. They have good kidney function, and they really shouldn't be at any increased risk that they don't have because of their age or other disease and so on. A few donors donated a long time ago and have got a lot older and don't have completely normal kidney function anymore, like is true of many older people, even who haven't been kidney donors. So I don't want to say, if you've been a kidney donor, don't worry, but for the great majority who are well, it's not a special issue for them.
Okay.
In fact, that's probably true of Alports. There isn't anything about Alport in particular which makes the COVID concern greater. It's all to do with how good your kidney function is and so on.
Fantastic. Final couple of questions now, if that's okay. We've got a question from someone who's been asked to shield in their shield someone in their family. Sorry. What sort of activities can the family undergo whilst they have someone in their household shielding? Could they, for example, be a responder? Could they send other kids to school?
Yeah.
What are the circumstances around that?
Whenever you start getting down to the detail of how people should behave, it really comes to hit you. Clearly, if you live in a big house and have multiple bathrooms and so on, you're in a very different position from the reality for many families. If you share a premises with someone who is unable to protect themselves in extreme because, and this is true of one of our patients actually, whose girlfriend is an A&E nurse, then he's gone back to live with his parents. It's really, really difficult to be vigorously protective and shielding in a small house, and this is the reality. It's almost impossible, I think. I think family with young children are going to find themselves in the same position, and we are going to have lots of conversations trying to help people come to some sensible decision about how a reasonable way of the safest possible way without being daft across the next very long period.
I think Boris Johnson called it good British common sense. Well, thank you very much, Neil. I really appreciate it. I think we can move on to our next speaker now. I believe that is Professor Rachel Lennon. Would you mind sharing your screen now? Perfect, we can see your screen. Please go ahead.
Okay, let me just get the, okay, oh yes, more and chat, brilliant. Okay, so yes, thank you, Patrick. And just to introduce myself very quickly, yes, I'm a paediatric nephrologist in Manchester. And ordinarily I combine a research role at the University of Manchester, where I run a research team that focuses on Alport syndrome research. And I'm a clinical consultant paediatric nephrologist at the Children's Hospital. But since the lockdown, I've moved to a full-time clinical role to support the department. And we've been working a full shift rota actually in paediatrics, in paediatric nephrology, so that we can manage to keep the department going and make a lot of those, take part in the communication that Neil's already introduced, that has been a big focus of what we've needed to respond to during the pandemic so far. So I'm going to focus on concerns in children and young adults regarding COVID-19, but just by way of introduction, I'm just going to start with an introduction here, an introductory slide to the kidneys. So most of us will be born with 2 kidneys, and within the kidney structure, we have these individual functional units. So there's about 1 million nephrons in each of our kidneys. And the top part of the nephron is this structure here, which we call the glomerulus, Neil mentioned earlier. And this is the kidney filter. And what we know is that this fairly unique structure has lots of tiny blood vessels. These are called capillaries within the filter. And they essentially allow the blood to flow through, so the dirty blood to flow through and filter across this barrier here. And within this structure, the glomerulus, we know that there are particular cell types, and I've labeled them here. So the podocyte here looks a bit like an octopus, the mesangial cell in the middle, and these are the tiny capillaries. And so if we zoom in to this structure here, this is the blood vessel wall, the glomerular capillary wall, and it's got specialized cells on the inside. These are the feet of the podocytes on the outside, and then you've got this very important structure here, the glomerular basement membrane, which I'll come back to a little bit later on. What's quite remarkable is that through our 2 million glomeruli, if we roughly average that out in our 2 kidneys, then we filter about 180 litres of plasma a day. So quite extraordinary structures, but very important. So that's a very quick introduction to the normal scenario. What we know in kidney disease, and disease particularly that affects these kidney filters, is that you can start off with these healthy filters, and then for a number of different reasons, including genetic problems such as Alport syndrome, then we can see changes in this very delicate structure here, the capillary wall, and we see changes both in the cells and in this basement membrane structure. And as that progresses and more of these filters are affected, then we start to see this sort of pattern. When we do kidney biopsies, for example, we can have a look at the filters, and we can see that scarring develops. And when you get to this sort of level, then this structure is no longer working well as a filter. So in terms of what we call this from a clinical point of view, then, or how this would present, then when the filters aren't working and they look a little bit like this, then this is when the kidneys will leak protein. When they stop working and stop filtering, that's when we progress in terms of chronic kidney disease, and we have these stages that Neil's already introduced. In terms of the treatments that we might use, then for some types of kidney disease that affect the glomerulus, then we might want to suppress the immune system. That's not a treatment that we tend to use for Alport syndrome, but it's relevant for COVID-19. I'll come on to that. And then, of course, dialysis and transplantation. So that's just a very brief introduction. I'll come on to talking more specifically about Alport syndrome after the next couple of slides. But I thought I would just focus now on some of the questions and concerns that we've had come through to our unit in Manchester. So firstly, about the risk of this novel coronavirus. When we're thinking about children and young people, actually, as Neil's already said, very small and very low numbers of children and young people are requiring hospital admission. And I can certainly share the link here. There's a really good summary if people want to delve into the information, but there's a really good website, Don't Forget the Bubbles, which has put together a lot of the evidence that's coming from across the world about this infection in children. What I should say, actually, throughout this whole experience that we're having with the pandemic, it's been quite remarkable in terms of how information has been shared and how we're learning all the time, and definitely making forward progress in our knowledge and understanding about the coronavirus and COVID-19. The other thing that we're starting to hear reports about, although still very low numbers and rare, is an inflammatory syndrome that has been reported in children. that we think might be related to coronavirus infection. And that's had some similarity to a condition that we've known about in pediatrics for a long time, called Kawasaki syndrome. And this is something that we're starting to explore and wonder whether it's connected to having had an exposure to the virus. The other feature that I think I put within the risk of this pandemic scenario is that actually in pediatrics, one of the things that we have observed is a reluctance of some families to come to hospital when children are unwell. And so we've certainly seen a late presentation of non-COVID related problems. So it's still very important for children to come and be seen at hospital if they're unwell. Shielding. So this is an ongoing discussion. We have very early on during the pandemic, we got together as a group of pediatric nephrologists nationally and started to put together our thoughts and recommendations for shielding. And I've just highlighted the risk groups, the high risk groups there that we have certainly recommended at the local level shield. And there's some, this is repeating some of what Neil has said, but the patients who've had kidney transplants, who are on dialysis, the lower GFR levels, those that are on immunosuppression, and those that have nephrotic range proteinuria, and we've got a particular measurement cutoff there. So that's what we're currently recommending. Certainly when the first information came out centrally from the government, there was a lot of discrepancy, and some of the lower risk patients were advised to shield. And we've needed to update that information at a local level. What about school? Well, currently that's the schools are closed, but we're hoping that they will reopen. And when they do reopen, our advice currently is that the low risk children will be able to return. Actually for other patients, and also for those that are in that shielding group going forward for however long we need to go forward, I think what we're expecting to do is to have individual plans from clinical teams, where in a clinic letter we would give an indication of whether we've had a discussion around shielding and what that recommendation would be. Some more concerns, I think this is, Neil raised the current treatment with ACE inhibitors and angiotensin receptor blockers. There's a nice summary about this if people want to delve into that information further. But just to reiterate, there's no change to current treatment plans that we're recommending based on the information that we have so far. Transplantation, this is another significant issue. In most UK centres, the programmes have paused. I think 2 or 3 paediatric centres have continued to transplant because it's been safe to do so. So in Birmingham, in Belfast, in Glasgow, the programmes didn't need to pause. And now individual units are considering the options for restarting. And so we need to know and think about all of the safety issues to make sure that that happens, but primarily happens when it's safe to do so. And what about research and the COVID-19 related aspects? Well, I guess in terms of many clinical trials that have been ongoing, then in this first lockdown period, many have paused recruitment. In terms of funding for research, then a lot of our charity funders are expecting reduced income over the next 12 plus months. Certainly as researchers, we've seen postponement of deadlines for funding applications, and labs across all UK universities are currently closed. So only for, in most universities, any COVID related research is ongoing, and any clinical trials where patients may come to harm if the their appointments aren't continued. So there's a very small amount of research that is ongoing, but for the vast majority of us, particularly working on kidney research, then this has been paused. But what we're all really keen to do, and tonight's a great example of how we're able to do that, is to keep the momentum going and to connect in the new ways that we're learning to connect. So just a few more slides going back to some of the basic structure and function of the kidney and the glomerulus and the changes that we see in Alport syndrome. So just to remind you, this important structure, the capillary wall with the basement membrane. In Alport syndrome, we know this structure is abnormal. And it's abnormal because of a particular protein called type 4 collagen. We're going to hear more about type 4 collagen and the genes that make type 4 collagen from Francis and from Lizzie in the next two talks. But this is the primary problem in Alport syndrome. And here's the structure in the kidney, but there are basement membrane structures that are particularly vulnerable in our cochlea and also in our eyes. And so there are features of Alport syndrome that affect those parts of the body too. What changes to this basement membrane? So just some pictures here of the type of patterns we can see from kidney biopsies in Alport syndrome. So these two pictures here come from looking down a light microscope, and we can look for the particular types of collagen. We can look for particular patterns, and there's one pattern I've highlighted here called FSGS, which we're starting to connect a little bit more with types of Alport syndrome, but it's one of the many patterns that our pathologists will report when we look down the light microscope. When we go to higher power with a more powerful electron microscope, then these are the sorts of pictures that we can see. So here's that capillary blood vessel I showed you earlier. Here's the basement membrane, and here is the inside of the basement membrane. This is where the blood is, or inside the blood vessel, and you can see a red blood cell escaping across, and that'll find its way down into the urine, so that when we use the dipstick, we can pick up blood and protein, often in the urine, in patients with Alport syndrome. And here's just that picture of the abnormal basement membrane you can see here, which is thickened and split, and this causes that leak of blood and protein from the kidney filters. What we now want to understand is what is the impact of COVID-19 and this coronavirus on the kidneys. And Neil mentioned a paper that has done some of these studies looking for the virus in the kidneys. And I should say there's a lot more for us to learn about the types of cells that this virus infects. Why does it cause a particular problem in the lungs in terms of the responses and the severity of the symptoms in the lungs by comparison to the kidney? There's plenty of questions that we still need to answer there. Finally, last two slides just on current treatment for Alport syndrome. And our priority with our current treatment is to delay kidney failure, delay the progression of the disease. And this is just a table that we put into a paper that was published in print actually just this month from one of our previous workshops in Glasgow. And on the green upper panel, these are all the protective medicines that we might use to reduce blood pressure if it's high. And I've just highlighted ACE inhibitors as one of the treatments there, which is really important in Alport syndrome. And we know from studies that can help the kidneys to survive for longer, for 10 to 15 years, and perhaps even longer. So really important treatment for Alport syndrome. On the blue bottom part of the panel, these are the things that we know can increase the progression of Alport syndrome. Final slide is just thinking about the trials that are coming through. And the first thing to say is it's amazing to see so much interest in Alport syndrome over the last, I'd say, 5 years. We've got the first 2 clinical trials in progress in Alport syndrome. One of a treatment called anti-MIR21. That's a trial that is currently recruiting. It's paused due to the pandemic, but is still likely to continue in 3 or 4 countries that are already set up to recruit patients, including the UK. And then there's another treatment trial of bardoxolone, which is in the United States, which is run by is led by a company called Reata. So 2 current clinical trials that are aiming to see whether these new treatments can prolong kidney function even further than the ACE inhibitors. But there's more coming through in the pipeline, and I think this is the really exciting aspect of Alport syndrome research at the moment. And I've listed some of the examples there. And I should just finish up by saying that in terms of rescuing the problem and gene therapy, so you'll hear in the next talk from Francis all about the genes that we know cause Alport syndrome. Can we correct that gene mistake with gene therapy? And there's certainly renewed interest in this area as a possibility in Alport syndrome based on the success that we're seeing in other areas for other conditions. So just a little introduction there for clinical trials in Alport syndrome, but we're hoping that this will be an entire webinar in the next few months ahead. So I can finish there.
Fantastic. Thank you very much, Rachel. Really appreciate it. Obviously, we've got a bunch of questions. If you have anything else, please use the Q&A function now. Otherwise, I'm just going to go through what we have already.
Okay.
I've got a bunch of questions about the various different things that you talked about being delayed, on hold. Let's start with one on kids keeping fit during lockdown. I think we talk about fitness. I don't know whether you mentioned it in the presentation, being quite an important part of helping continue your kidney function. Do you have any recommendations for kids trying to stay fit during the lockdown in spite of not being able to go outside as much?
Yeah, I mean, I think it's, so you're absolutely right, Patrick. It's a really important aspect, and it's something that we should promote. Cardiovascular health is so important for kidney health. And I think probably the key, my recommendation would be to find something that you enjoy, whatever that might be, whether that's getting out for a walk, if you're a runner, getting out for a run, cycling. And those are activities that we can, do safely with the social distancing that we need to live with at the moment. And I guess the frequency of that, as long as we're maintaining that distancing, is going up, at least in England, as of this week. So we can go out more than once a day. And yeah, I think my tip would be to think of something that you can put your mind to and that you enjoy, and try and build that into the structure of your day and your week.
I've got Katie Brown in the chat saying that Joe Wicks is great for kids. I absolutely agree. I was exhausted. I never realized how unfit I was. Anyway, I want to talk about the transplant program because a few people, including myself actually, are waiting on transplants that have been paused due to the COVID crisis. What are the sort of tests? What are the circumstances that we might see a return for the transplant program?
Yeah, so this is very topical. We had a 2-hour meeting yesterday in Manchester in my department where we were just discussing exactly this. So together with our transplant surgeons, figuring out what is the safe way for us to go forward. And actually, what we're likely to do is start in pediatrics, because we don't see so many cases. We have very few children that are needing admission with COVID-19 to the Children's Hospital, so we're a relatively clean site. But then we have gone very carefully through the whole protocol. So most centres will have a really very detailed protocol for kidney transplantation. And so we have gone through every aspect of that to say, now how does this need to change in the light of COVID-19? And so there's aspects around the consent that we need to discuss. There's aspects around testing of the donor, testing of the recipient at the point where everything's ready to go. And so that's what I expect most units are going to do, to reevaluate their working protocols and figure out how that needs to adjust to the new situation.
Is it fair to say that that decision will be based, will be very dependent on where you are? It's not going to be a nationwide rollout.
Yeah, I think that's right. And I think it's anticipated in some areas where there has been a very high level of infections. And if a particular hospital where transplants are routinely performed, if there are a lot of patients continuing to be admitted with COVID-19, then they're likely to be longer in terms of their delay and before it's safe to restart. But I have to say that, you know, we're thinking about, we need to be creative in this situation and think about alternatives. So, you know, there's lots of, as Neil said, actually, it's really great to have this collegiate nature amongst the community in health and care, trying to solve the problems that we're now facing.
Fantastic. Someone's asking a question about masks. I don't think was touched on in the presentation. Any utility to, especially if schools are going to reopen, sending people into the schools with masks? Is that useful at all for Alport patients?
Yeah, I mean, I think some of us are, you know, looking elsewhere. You know, there's clearly different practice elsewhere in the world, and you know, there is certainly a practice in hospital on wards in terms of what we're doing when we, you know, there's no confirmed cases within our wards, we're still wearing masks because we do know there is this possibility of asymptomatic transmission, and so you know, I think we will be, I guess, led and guided by what comes through from the government, from NHS England and Public Health England in terms of a national policy. But what we understand is that actually we are protecting others by wearing a mask ourselves. The value and use of that mask to us in terms of protection to ourselves is less sure, but in terms of passing it on, and so that's one reason behind wearing the masks on our wards as healthcare workers. Sure.
I think also a couple of questions of clarification, if that's okay.
Sure.
I've got someone who's been shielding, but is due back to school on the 30th of June with a DGFR of 23 and a protein of 238. Should people that are shielding be going back to school, especially in this case as they are a teacher, not a child, so perhaps slightly above the age where COVID is almost wiped out?
Yeah, so I mean, these are the tricky decisions, and as Neil mentioned earlier, then I think actually this is a hard decision for you to take by yourselves, and that's
Sure.
where we come in. And certainly, you know, over the last 6+ weeks we've been fielding many such questions, so I'd really encourage people to link to their clinical teams and to have it, you know, in some cases it will be a personalized decision. There isn't one size that fits all in terms of recommendations here. But certainly some of those elements in terms of level of GFR and proteinuria would put that individual in a high risk group currently.
I think it's absolutely crucial that we emphasize that if you do have any questions that are related specifically to you and your circumstances, that you should be talking to your clinicians, because they're going to be the ones that are best educated about this. Also on clinical trials, which you mentioned there, which is really, really exciting. I think we've been looking at those for a good few years in the Alport community. I'm assuming those have got quite substantially delayed time frames as to when we might have an outcome. due to the COVID crisis.
Mm.
What are we looking at? I know this gets our every workshop. What are we looking at in terms of a time frame for drug trials progressing on?
Yeah, no, it's a really good question. I think, again, those individual infrastructures, the companies that are leading the trials, the clinical trials facilities that are hosting the trials will all be looking at their individual protocols and considering the safety aspects. And so, you know, I think for trials where the treatment may be impacting on the immune system, which is not really the case for the treatments that we're seeing coming through for Alport syndrome, but you can imagine that there's going to be more of an issue for those clinical trials. But essentially, the pause button will be activated until it's safe to bring individuals into for recruitment for site visits. Perhaps there will also be a rethinking in terms of how much needs to be on a particular site and how much could be done remotely. I had a communication with Sanofi, one of the companies running one of the current trials at the moment, and they haven't got a current indication of when that's going to start up again, but it has started and it's paused and it will restart when it's safe to do that. So hard to give a time frame at the moment.
Cool. I've got a final one, I think, from Kieran, who's a key worker. Just looking at ways that he can keep himself healthy whilst he's at work. Is the advice specific for Alport patients, or would you recommend general awareness?
Yeah, I mean, I think as a fellow key worker, yeah, we all have been needing to think about this at an individual level, and I think, you know, I'm sitting in my office at work at the hospital at the moment, and one of the things that we realized was actually 6 people in an office, we're not going to be able to social distance very easily in here. So some practical local decisions based on your individual setup, and what we fairly quickly did was say, okay, we're going to have a maximum 3 people on site at any one time in this office, because otherwise we can't maintain social distancing. So I think we have to use that common sense in the workplace as well.
Okay. Well, thank you very much, Rachel. I really appreciate it. We now need to move on to our third speaker of the evening. We will, of course, I should say we have a few questions left for Rachel that we can address at the end if we have time. Our third speaker is Professor Francis Flinter. Francis, would you mind sharing your screen, please? Okay, I think we can see it. You have 10 minutes. It starts now.
Okay, thank you very much indeed. Well, hello everybody. It's great to be linked up with you in this way. My name's Francis Flinter, as you know. I am a clinical geneticist who's had an interest in Alports ever since I first met some families on Dickens Ward at Guy's back in the 1980s. In fact, I retired from clinical work last year, but like many of my friends and colleagues, with the outbreak of COVID, I'm now back at work, although not working in the genetics department. And I'm going to try and tell you a little bit about the way Alports is inherited, and also consider why it is that, in addition to the kidneys being affected in the way that Rachel has described, other organs can also be involved. Just one word of warning, my husband any minute now is about to join a choir rehearsal by Zoom, but I hope you won't be able to hear him because I've closed all the doors between us and told him to sing quietly.
Oh, we've all been there.
Right. Now I'm just trying to get to the next slide and it's not going on. There we are. So this is the wonderful Professor Arthur Cecil Alport, and Susie mentioned to me that his granddaughter Carol is hopefully one of the participants listening to this webinar today, which is wonderful to have that link with the original family. Arthur Cecil Alport was a very eminent physician who for a while worked at St Mary's Hospital in Paddington, and the reason the condition came to be named about him, although it's probably been around for centuries, is that he made some very astute observations, and two things in particular. First of all, he commented that in the families he was seeing, the males were affected much more severely than the females. And of course, we now recognise that that's a feature of X-linked inheritance, but at that time this was not understood. And secondly, he made the observation that he didn't think it was just chance that some of the people who had kidney problems also had some hearing loss. He reckoned that the two went together and were being inherited in the family in the same way. And in other words, what he did was identify that this condition is a syndrome. It doesn't just affect the kidneys, it can also affect hearing. And the word syndrome means a constellation of different features affecting different parts of the body, which are not just a chance association, but actually have the same underlying cause. Now, I understand that one of the questions that's come up in the Facebook group is wondering whether there's a single common ancestor, as we know there is with some other genetic conditions, but that's certainly not the case with Alport's. In fact, most families are not related to each other. Most families have a different alteration, different mutation in the Alport gene. And so that proves that it's not inherited from the same common ancestor. And even in families who do have the same mutation as another family, it's quite likely that they're also not distantly related. It's just a part of the gene where perhaps it's a bit more common to have mutations arising. And we've worked out over the years that around 15% of patients who have Alport syndrome have the condition as the result of a new mutation that's just started in them. It's not been inherited from further back. And we've also learned over the years that the X chromosome is a chromosome in which new mutations occur fairly frequently. So it's not that unusual for someone to present with feature of Alport syndrome without having had a family history of the condition in previous generations. So what causes Alport's? Well, it's caused by a mutation in a gene that makes, as Rachel described, a type of collagen. Collagen is a protein. There are many different types of collagen in our body, but there's a particular type of type 4 collagen that has a role to play in the kidneys and the ears and the eyes. And that's why those are the three parts of the body that are usually affected. I understand that there are a couple of people who may be on the call who have an incredibly rare association with Alport syndrome, where they also get some tumours in the smooth muscle of the esophagus, the gullet, and these can also occur in the uterus. That's actually caused by a specific mutation which affects the X-linked gene, but also extends across to affecting part of the gene next door. So if people present with Alport's and these smooth muscle tumours, we know even before we do the genetic testing that they must have X-linked Alport's. But of the many hundreds of families that I've seen with Alport's, I've never actually met a family who has this combination, so it is an extremely rare one. Now, talk a little bit about the hearing. This is what we call an audiogram, and I'm sure many patients will have had this done. On this scale, the number shows how loud the sound has to be, before you can hear it. And on this scale, this is the pitch of the sound. So low-pitched noises here and very high-pitched noises here. And this is an audiogram of someone with normal hearing. So they can hear even very quiet sounds, both at low pitches and at high pitches. This is an audiogram of somebody who has got moderate high-tone sensorineural hearing loss. So the sound has to be at a volume of 30, 40, 50, even 60 decibels as we go to the higher tones before they can hear it properly. This is the right ear and this is the left ear. So this pattern with the hearing loss sloping down like that is typical of somebody with Alport's. And that's because the type 4 collagen that we find in the kidney is also found in the ear. And so if there's an alteration in the gene that makes that, that means that the type 4 collagen in the ear is also not quite formed normally. Now, it is very important that if people develop hearing loss like this, they can be helped with hearing aids, but you need to wear your hearing aids every day so that your brain gets used to using them, and so that it can benefit from the amplification of the sound that the hearing aids provide. If people only put them in very occasionally, they'll find that they don't get very much benefit for them, and then probably will be rather less inclined to wear them. The other thing that's always an important message to give to people who do have some degree of hearing loss is to avoid exposure to really loud noises, and particularly avoid being plugged in to loud sounds for long periods of time, because that can do further damage to your hearing. Moving on to the eyes, because this type 4 collagen is also found at the back of the eye. This is a photograph taken through the pupil of the retina at the back of the eye. So these little red marks are the blood vessels. This is the central part of the retina where the image that we're looking at is focused, and hopefully you can see around the edge lots of little tiny white dots. Those are called macular flecks. Now, they don't affect the vision at all, but they're very important because Alport syndrome is the only thing that causes this pattern of white macular flecks. And so a very clever ophthalmologist who happens to be looking at somebody's eyes for some unrelated reason, who may spot that and realize that the patient has Alports, and in fact be able to diagnose Alports without knowing anything else about them. So we now do encourage patients where we're not sure whether or not they might have Alports to consider referral to an ophthalmologist, because there may be additional clues there that could be helpful. The other effect that Alports can have on the eyes, which people do become aware of, is it changes the shape of the lens so that when you shine a light through it, the light is reflected back at a different angle. This change in the shape of the lens is known as anterior lenticonus, and what it does is cause short-sightedness. Now, many of us are short-sighted for all sorts of other reasons. What's characteristic about the short-sightedness that occurs with Alports is that sometimes the prescription that you need can vary quite a bit over a short period of time. It may fluctuate. The strength of glasses needed may go up and then may go down a bit. And very occasionally it becomes so difficult to find a prescription that works and is still okay a month, 2 months, 3 months later, that people may have the lens removed and an artificial lens put in, which can get round that problem. So if you have short-sightedness and you're a patient with Alports, it's worth telling your optician that that's what you've got when he or she is thinking about the best way of treating your short-sightedness. Now, I said I'd talk a little bit about the types of mutations that can occur in Alports, and as I've mentioned, I'm slightly hesitant about trying to go into a lot of detail about the genetics, because really for every patient this needs to be a separate personalized conversation tailored specifically to their genetic test results. But I'll try and give you a summary in the hope that that is useful. I think Rachel mentioned that some mutations we know are milder and some more severe than others. And whilst we can categorize mutations to some extent like that, there's quite a range even within the severe group and the mild group, which means that it's never really possible to give anybody an accurate prediction as to what sort of age they're likely to get to before their kidney function starts to decline, because there are all sorts of other factors that will have a role to play as well. We know that about 85% of patients with Alports inherit their condition from their one or other or both of their parents, and about 15% have Alports as the result of a new mutation. But as I've said, there's lots of other modifying factors. It's not just the specific mutation or mutations that a patient has that will determine their clinical course. Increasingly, we're learning now that there can be genetic variants in other genes that are important in the kidney that can also have an influence on how somebody's clinical course goes. In fact, I've always found that the best clue you can get when somebody wants to know what's likely to happen to them, if they have other family members who are affected, is to find out what their clinical course was. And if a boy who's been diagnosed with X-linked Alports has an uncle who didn't go into kidney failure until his 30s or 40s, then it's very likely that the boy will follow a similar course. Of course, we can modify that still further by adopting a healthy lifestyle, keeping fit, not getting overweight, not smoking, and in particular by ensuring good control of blood pressure and the leak of protein into the urine, proteinuria. It's quite astonishing, really, over the last decade, how much we've learned about the significant improvements, the dramatic improvements that you can achieve by using drugs such as ACE inhibitors to keep good control of blood pressure and the protein leak. And that can extend the working life of the native kidneys, the person's own kidneys, sometimes by 10 years or more. Now, just a quick summary of the two main types of inheritance that we see with Alport syndrome. First of all, I'm going to talk about X-linked Alports because that's much the commonest. It's the pattern of inheritance that affected the family that Alport described in his seminal paper in the BMJ in 1927. As you probably know, males have one X and one Y chromosome, and females have two X chromosomes. I went into a primary school once to give a talk about genetics, and I explained the difference between boys and girls. And the next day, the teacher told me that apparently one of the children went home and told her parents about the talk that I'd given. And she then came back the next day and said her dad said, I must be wrong because there's definitely more to it than that. Anyway, this is the fundamental basis of X-linked inheritance. And because people with X-linked Alports have a mutation in an Alport gene on the X chromosome, that means that males only have one copy of that Alport gene. And so if there's a mutation in it, they will inevitably be affected by it. Women have two X chromosomes, but in every cell, one of them is switched off, and it's random from cell to cell which one is switched off. So women with two X chromosomes actually have two copies of the Alport gene. They may have a normal copy and they may have an altered copy. If they're lucky, in most cells in their body, and particularly in their kidney, they will have switched off the X chromosome that's got the altered copy, and therefore their normal chromosome can largely compensate, and they may well have very few symptoms and signs. Now, there's been a huge debate and quite a transatlantic difference in terms of the language that we use to describe women who have one normal copy of the X chromosome and one altered copy. Amongst geneticists, we generally refer to people like that as carriers, although they usually develop some signs. Most of them will have blood in their urine, and so we may describe them as manifesting carriers. But some will go on to develop a protein leak and high blood pressure, and a minority develop kidney failure. And at that point, we would describe them as having Alport syndrome. I'm aware of the fact that in the States and in some other parts of the world, women, even if they're completely asymptomatic, will be labelled as having Alport syndrome on the basis that they have a mutation in the Alport gene, even if they have no symptoms and no signs. So it's important, whatever language we use, that people know what it is we're talking about. For women who have X-linked Alports, the majority have a much milder clinical course, but the effects are unpredictable. So it's very important that they're having at least annual screening to have their blood pressure checked and their urine tested for protein and any abnormalities detected. We know that compliance with screening and medication certainly improves the long-term prognosis. Now, there are questions about what does this mean for children? When a man has children, it's his sperm that determine the sex of that child, obviously something that Henry VIII never understood. He always blamed his wives for having daughters rather than sons. If a man passes on his Y chromosome, he will have a son, and that son will be unaffected because that son will get a healthy X chromosome from his mother. If a man passes on his X chromosome, his daughter will inherit his Alport mutation, and so she will have one normal and one abnormal X chromosome. She will, of course, get her normal X chromosome from her mother. If we look at women who have a mutation in one of their two Alport's genes, every time they have a child, there will be a 50-50 chance of the child inheriting either the normal Alport gene or the altered Alport gene. In other words, a 50% chance if she has a son that he will be affected, and a 50% chance if she has a daughter that that daughter will be what I would term a carrier, but with a risk of developing features of Alport syndrome. And lastly, let's look at the inheritance pattern for the much rarer form of Alports. This is known as autosomal recessive Alport. So this is
Right, so I just want to let you know you're on 16 minutes, so we'll have to wrap up at some point, just because we've got a lot of questions.
That's fine.
I'll just let you continue.
I've nearly finished, that's fine. So for recessive Alports, this is a pattern of inheritance like cystic fibrosis and Alport syndrome. If both parents are carriers, every time they have a child, there's a 25% chance of the child being affected, a 50% chance of the child being a carrier, and a 5% chance of neither. If just one parent is a carrier and the other isn't, then there's a 50-50 chance each time they have a child of the child being a carrier. And if one parent is affected, but the other is neither a carrier nor affected, then all their children will be carriers, but none of them will be affected. And so I just want to finish by acknowledging the huge amount of work that Alport UK has done in convening international conferences that have enabled Rachel, Neil and I and many others to get together in a number of different countries to share the very impressive results of early treatment with things like ACE inhibitors, to be aware of what new drug trials are both underway and pending. There's been a huge amount of work in the genetics community to identify underlying genetic factors that can modify the clinical course of the disease. And this is definitely for a future webinar, but early trials of gene therapy are now underway in animals. Thank you.
Fantastic. Thank you so much, Frances. I really appreciate it. I've been watching these presentations develop over a few years and I'm still learning things. So it's just fascinating to watch this. I've got a few questions as usual. If you have any questions for Frances, you can just bung them in the Q&A panel. Otherwise, I think we should start with someone asked a question about hearing aids. You mentioned that it was beneficial to wear them. I think it's important that we emphasize that that is important. But what age do you think people should start wearing them? How do we tell?
The age at which hearing loss becomes apparent varies hugely. On average, it tends to be around the end of junior school age. So I think it's the person who does the audiogram, the hearing test every year or two, who will be able to advise whether or not hearing loss is sufficient to justify prescription of a hearing aid.
Sure. And with hearing aids and eyes, there are specific differences that opticians and audiologists can look for that would indicate that it's due to Alport and not just some other mutation. For example, we've got someone saying that their daughter has been diagnosed with keratoconus in both eyes. There are specific characteristics of Alport hearing or eye deficiencies.
So the eye signs that are specific to Alports are anterior lenticonus, the macular flex, and also sometimes people get a dry eye. I know a lot of people have noticed that that's a problem and they need to use eye drops to keep their eye moist. The hearing loss is not really specific to Alports. There are many different causes of sensorineural hearing loss. And there are many people who have sensorineural hearing loss who don't have Alports. So just doing an audiogram doesn't make you think, oh, I wonder if this patient's got Alports, unless you're aware of other features in the kidneys and so on. And occasionally we've seen people who have a very significant hearing loss and just a bit of blood in their urine, and further investigation has revealed that actually the cause of their hearing loss is something quite different.
Okay, final question, because I want to move on to Elizabeth's talk. You talked briefly about women with Alport syndrome. Should women be tested as male presenting carriers are, as male presenting people with Alport syndrome are, on a yearly basis, half yearly basis? What are we talking in terms of their blood?
For people who are well, a check of the blood pressure and the urine once a year as a screening. If the results are normal, they can probably wait another year until it happens again. The person doing the screening, when they get the results, will be able to advise whether it's safe to wait for another year or whether it might be better to be screened again in perhaps 6 months' time.
Okay, thank you very much, Frances. It's time to move on to our final speaker. Remember, we do have a final question and answer session at the end if you have any final queries for Frances. For now, we're going to turn to Elizabeth Watson. Would you mind sharing your screen now, please?
Oh, there we go. Can you hear me okay?
We can see it. You have 10 minutes. Go ahead. Okay.
So firstly, I'll just introduce myself because unlike all the others, I'm not a doctor. So I trained as a scientist. I did an undergraduate degree in genetics in Edinburgh, and then following that I trained to be a clinical scientist. and I've been in my current post for about 2 years now, and I lead the Inherited Renal Genetics Service based in Bristol. So this is just a photograph of our lab here, so on the right, so you can see what sort of building we're working in, and we're in there integrated with a lot of other pathology departments. So your haematology and biochemistry tests and your genetic tests all get sent to this building, and that's where we process them. So my slide is not moving, there we go. So here's a little photograph of the team that we have. On the call today we do also have Jessica Norton, who's on the right, who's one of our scientists in the team, and she works mostly with the Alport's referrals, but also other types of patients who have proteinuria and hematuria. And we also have Dr. Celia Duff-Farrier, who works with another type of patient group called that have cystinuria. And my boss is in the middle there, that's Maggie Williams. And some of these names might be familiar to you if you ever see your genetics reports. So at the Southwest GLH in Bristol, we've recently, as of the end of last year, become a designated specialist centre for renal genomic testing in England. And we are one of 2 providers for that type of testing. But as of April this year, we are now the sole provider of Alport syndrome testing for patients in England. And that might change next year as Great Ormond Street develop their testing. So where you live in the country will determine where your sample gets sent for analysis. So in Bristol, we perform a number of different tests for patients with inherited renal diseases, including patients with Alport syndrome. And the whole of the genomic testing pathways for all different types of patients, with all different types of patients with genetic disease, not just renal patients, has been completely overhauled by NHS England in the last 12 to 24 months. And as of April, there's been a new genomic medicine test directory that lists all the genetic tests that are available for patients and what criteria they need to meet in order to be eligible for that testing. And that's all available online. If you wanted to look it up, you could just Google the genomic medicine test directory if you live in England, and you can find out that information. So for patients who have a suspected mutation in one of the collagen 4 genes that Francis was describing, there are 2 different types of tests that you might be assigned depending on your clinical presentation. One of them is known now as the hematuria panel, and that's got 5 genes that are tested in it, including COL3, COL4, and COL5. And COL5 is the X-linked version that Francis was talking about. And there's also a much larger panel that contains 44 genes for patients who have a clinical presentation of just proteinuria. So there's the link to the test directory at the bottom if you wanted to pursue that. Oh, sorry. So Susie asked me just to give you a brief overview of what happens to your sample when it comes to the laboratory, and why it takes a lot longer than some of the biochemistry tests that you might be getting more regularly, and why it takes several months for that process to happen. So when we receive a sample into the laboratory, the first thing we do is check that it's suitable for testing. So we review the sample itself, check that it's in the correct tube, but we also check the referral form that's accompanied that sample. And this is to check that the patient information is correct and that the patient is eligible for the test that has been requested. And quite often we don't receive enough of that kind of information, so there's a lot of liaison that then goes on with the referring clinician around the sort of eligibility for that test that the patient has. So the type of questions we might be asking is a little bit more about the kidney function, what other pathology tests have been completed, and what the patient's family history is. We can then extract DNA from that blood sample, and once we've decided what the most appropriate test is for that patient, we can then start the technical processing. And this is several days of sample preparation before it's ready to then be sequenced. So that is looking at the DNA strands and looking at all of those letters that make up the DNA and looking for the types of changes that you might see in those in that sequence. So that's a process which takes several weeks quite often, and it's done on a batching process. So sometimes you might have to wait a couple of weeks before the sample can be processed while it waits for others to come in. So that's the current process. And once it's been processed, it goes through something called a bioinformatics pipeline, which I won't pretend to understand too fully, but it's just looking at the quality of that sequencing and making sure we have the most quality results that get presented to us for analysis. So there are a few improvements that we're doing now to make sure that the samples can get through even faster. So what we'll hopefully see towards the end of this year is that patient results are leaving the laboratory a lot quicker than they were at the start of the year, although obviously there has been some disruption with COVID. Luckily, at the moment, we're not having to do any COVID testing, but we are on standby for that. But at the moment, we are currently able to operate a near normal service for our inherited renal disease patients. So we've made some changes recently that should help these samples get processed a lot quicker. But really the bulk of the work and why it takes so much time is because the analysis of genetics results is incredibly complex. We have highly trained individuals that are analysing these results, and what you see is not just one result that gets returned back to scientists, but quite often you see over 100, or I was looking at just a simple test today and there was 160 variants were returned. So these are just changes in the DNA sequence that we need to look at, and lots of these can be dismissed easily because we know that those changes exist in normal healthy patients. But in most cases, around 10 variants will need a lot of thorough investigation, and it can take days or even weeks sometimes to gather all of that information for interpretation. And we look at many different things in order to determine whether or not a variant is benign and not associated with disease, or pathogenic and associated with disease. And these can be lots of different factors, and just I won't go into them just to save some time, but if you want some more information on that, I can definitely provide you with that. And one last thing to say about that is that variant interpretation is standardized across all of the NHS laboratories, so we are all making the same decisions no matter where your testing is being done. But also there are international working groups around how to interpret specific genetic variants. So there, for example, I sit on a panel now for an international panel that's led by a group in Australia around how to interpret changes in the collagen genes. So why does it take so long to gather that information? Well, mostly it's because lots of these changes are really rare, and we're trying to find out as much information as possible so that we can give the clinician the most informed result that we can get. So that usually means getting information from all sorts of different sources. So we might need to go back to the referring clinician and ask a little bit more about the patient's presentation or the family history. We might need to liaise with other laboratories as they might have seen that variant, and that gives us a little bit more evidence about how that variant is behaving in people. We also communicate with other laboratories outside of the UK where Alport syndrome testing is being completed, and we also correspond with research groups and try to gain some kind of functional information about those variants. So all of that work takes a lot of time, and once we've got all of that evidence together, we can then write the most comprehensive interpretive report back to the clinician as we possibly can. And one final comment is that in some cases we may need to perform some additional testing in order to confirm what we're looking at is what we think it is. So that's all I have to say actually, but hopefully that was useful and prompted a lot of questions.
Sure. I think one of the primary questions that we had was I think there's a USA testing program as well. What sort of collaboration are you doing with international laboratories? Because presumably if you see someone else's genetic type in another patient's abroad, that makes it easier to diagnose Alport syndrome.
Yeah, so there are some international databases that exist where not just Alport patients, but all types of genetic variants are uploaded to, and they will provide you with some information. So it might be that there's a report in the literature of that variant, their case report, or it might just be a diagnostic laboratory has uploaded that finding. But that's not to say that it's definitely causative, so they might, but it helps provide additional evidence when we're trying to assess that variant. So we, for example, we wouldn't see a report that's been uploaded by another laboratory to say this is a causative variant, and we would just say, oh yes, well definitely it is then. We then use that evidence and use it as part of our own assessment as to whether or not we think that's pathogenic. But we are, as I mentioned, I'm now sitting in with a group that are called ClinGen, who are based in the US but are being led by somebody in Australia. And at some point we will start talking a little bit more about variants and sharing the information we've got to develop our own criteria. And with Judy Savage, who works quite closely with Alport UK, we have recently had an international collaborative meeting. I think that was back in January, and we will be publishing the sort of the results of the discussions we've had around how to interpret Alport syndrome variants in hopefully in a recognised journal.
Sure. Well, I think more international collaboration can only be good for the diagnosis of Alport, right? I think it's fair to say that genetic testing takes so long because it's a huge number of factors, and consultation with more laboratories might help at least get that diagnosis.
Yeah, and we've had the experience where the demand for genetic testing is just going up and up, and we have had to respond to that as a laboratory by creating new tests and developments, which also have taken time to get into place. But this year was gearing up to be the year, and then coronavirus hit us.
So unfortunate. I was wondering as well, in the case of kids, would you recommend that people who know they have Alport syndrome ended up having kids, would you recommend that they get those kids tested so that they can be at least aware of potential symptoms developing down the line?
Yeah, so just to clarify, I'm not a clinician, so
Sure.
all I can do is
Sorry.
inform the clinicians of the results, and it would be down to that clinician then, so somebody like Francis or Rachel, to have those kinds of discussions about counselling and genetic testing in the wider family.
Sure. And maybe I pose that question to Francis then. Do you believe that sending a kid's results off to genetic testing would be helpful in making an early diagnosis of Alport syndrome and then maybe being able to treat symptoms down the line?
Yes. What we recommend is that people have a careful, considered discussion with their geneticist or genetic counsellor or paediatric nephrologist first, if they already know one, if they have children who are at risk of inheriting Alports, so that they understand what the implications are of having the test done, and that there's a plan in place for what to do with the result. So that if the child turns out they have inherited Alports, then obviously we would recommend that they are being screened regularly. And my personal practice has always been to refer them to the paediatric nephrology clinic to make sure that that's done properly. Healthy adults can sometimes be screened regularly by their GPs, but little things like measuring blood pressure in children is much more difficult because you've got to have the right size cuff, and doing blood tests on children is more difficult. And generally that's much more successful being done in a paediatric nephrology clinic, even though at that age the children are often actually very healthy. But because we know there are huge benefits to making a diagnosis early, because you screen them regularly and treat any proteinuria as soon as it emerges, it's actually in the children's best interest from a medical point of view to be diagnosed when they're young, rather than waiting until they present in adult life when they've already got significant kidney impairment.
Sure. I myself, I was pretty healthy for a while, and I think it was helpful to have that testing just to make sure that everything was staying okay. Okay, thank you everyone. I really appreciate it. Just because of the demands of time, we're going to move on to a very short final Q&A, just wrapping up any questions that anyone else has. If you have any final questions, please do submit them. Otherwise, I'll just go down the list. No real structure. I think we might as well start with Francis, considering we've got you on the screen. We had a question about genetic research to try and understand COVID-19 and whether there might be any treatments for that. Have you got anything there?
Yeah, as you can imagine, there's a huge amount of research going on, and previous projects such as the UK Biobank Initiative and the 100,000 Genome Project mean that there is already a lot of DNA stored, and a lot of it has already been subjected to an enormous amount of analysis and sequencing. The sequence is already sitting there in computers. The laboratory work that Liz is talking about is being done. It's a question of analysing a different part of the DNA. So yes, people are very actively looking to try and see if they can work out why it is that some people seem to be so much more significantly affected by COVID than others, and whether it's a function of some inherited alteration in the way their immune system responds to infection or not, we don't yet know. But yes, there's an enormous amount of work going on there.
And a final, perhaps slightly more difficult question about the options of having a family. You briefly touched on it in your presentation. For a female adult who's not yet started to think about starting a family, would they automatically be referred to genetic testing if they were thinking about it?
I don't think we should never rely on things happening automatically. But I think if women are thinking about starting a family, actually there's two conversations that they need to have. One is with their nephrologist as to whether or not this is the right time and whether it's appropriate for them to think about becoming pregnant and whether they'll need any extra care during their pregnancy. And the second is, again, ideally before they actually conceive, to ask for a referral to the local genetics department so that they can understand the pattern of inheritance of Alports in their particular family, understand what the chances are of their children inheriting it, and understand what sort of options are available to them if they would want to consider things such as screening during pregnancy or other options that could be there. We can't go into all of that in detail now, but yes, definitely people should ask their GP or their nephrologist or any other healthcare professional whom they know to refer them to their local genetics department for a detailed discussion about that. And we always prefer to see people before they're pregnant if possible, because there's just much more time to think about things carefully and make plans.
Sure. As always with these things, I guess we can only offer advice. I think it's probably best that people talk to their geneticist, as you said. I think we have a final question. Thank you so much, Professor Neil Turner and Rachel Lennon, for staying on, despite speaking quite early. Transplant logistics in COVID-19 are clearly going to be complicated. What are the specific demands to a patient that is going to need to have a transplant over maybe the rest of this year or going into next year that they should take into consideration? For example, should patients be shielding before they have a transplant? Should the donor be shielding? Is the transplant going to take longer or have to be in a specific facility as a result of COVID? What are the logistics around transplantations? I'll give that to either of you guys that wants to.
Shall I start on that, Rachel? So every centre is working out what they need to do to make transplantation safe where they are. In some places, like Northern Ireland, we've been hearing about it's been possible to move transplantation to a location where there's nobody with COVID, and I think this is important, and the background rate of infection in the local population isn't very high, so that the risks of getting it from members of staff or wandering around the hospital isn't so high. And you've got to remember that having a transplant operation, well, there's 2 weeks before in which you could get infected, or the donor could if it's a live operation. And then there's all that monitoring and visiting in the post-transplant period at a time when you're very heavily immunosuppressed. So there's no way of making this completely risk-free. At the moment, the risks of transplantation for anyone are going to be increased a bit. On the other hand, the benefits of transplantation are so good that you would want a transplant if at all possible. And I think it's going to be very locally variable. But as for advice for individual people, if you're heading for a live transplant, both donor and recipient want to keep very well away from infection. And that restriction for the recipient is going to last for weeks and months after the transplant as well. On the other hand, they're probably already shielding if they've got advanced CKD beforehand. Sure. For the donor though, and I see this question rising in the questions 2 or 3 times actually, for the donor, once you're over the operation, your risks are quite quickly going to go back to being those of the background population. You will not need to keep yourself more hidden away than everybody else, unless you're living with the recipient, which is the case in a lot of places, in which case you really do need to make sure you're not bringing infection back into the house. And this is one of the challenges of shielding people.
Sure. I think it's just important to take it seriously and get help as well if you can from your friends with groceries, that sort of thing. Well, thank you all 4 of you. I really, really appreciate it. We're going to finish by asking you to take part in our word cloud. And Rebecca should be sharing her screen now. There is a link in chat. If you click on that link or copy that link into your internet browser like Google Chrome or Internet Explorer, you should be able to submit a word there that tells us about how you felt having connected with the Alport community today. And once you've completed that submission, you can come back to the Zoom call and you should be seeing your words pop out in front of your very eyes. Just a word that sums up your experience with the workshop today. Oh, it's so pretty. I never get tired of looking at it. Fantastic. Lots of stuff coming in. And of course, if you hated it, feel free to send a lengthy email to info@alportuk.org. Anyway, I really appreciate you guys joining us today and for giving us your feedback. Thank you to Dan Long, who has been managing all of our mics and the video over the course of the session. And thank you, of course, to Rebecca Mull, who has organized the whole thing as well. I want to thank some of the speakers in particular. We know that we're all facing a global pandemic, but it is particularly difficult for you guys at this time, being on the front line of the pandemic. And I can't say how much we appreciate you taking the time to come in today and speak to us. For our viewers, we hope that you'll be able to join us for our next session. We'll be opening that up to the international Alport community and holding the next workshop on the 20th of May. It should be similar to this. We'll introduce the Lennon Lab from Manchester, who are going to be doing some really interesting presentations on their work researching Alport syndrome. We will share the video of this entire session to our Facebook page. And otherwise, we hope to see you on the 20th of May. Have a lovely rest of your evening and stay safe.